Hi, I'm Dr. John Kugler, and this is the Stanford 25 Ultrasound series. Today we're going to be talking about how to estimate the central venous pressure by visualizing the IVC. Of all of the scans that I do as a hospitalist, this is probably the most common one. And certainly when I look at my trainees, this is far and away the thing that they do the most with point-of-care ultrasound. And it's understandable. A lot of our patients have problems with fluid, whether they have too much or too little. So it's a frequent question that we're trying to answer, which is, what is this patient's central venous pressure? And the IVC has really helped us to get a better understanding of that. Now, I'm still going to recommend to all of you that, again, the IVC is one piece of data, and it's a great piece of data, but it's not the only thing that you should rely on. But let's make sure you know how to get a good picture of the IVC. So to do this, in general, you're going to have your patient lying flat. They can have, again, head of bed up a little bit for patient comfort, but in general, fairly flat is better. You need to be able to expose the abdomen so that you can get the probe to where it needs to be. I'm going to be using the cardiac probe today. You could use the abdominal probe. They both work. I do have it on a cardiac setting. As an internal medicine trained doc, that tends to be what I put it on, though there are some other people who might use the abdominal settings. It's not wrong. I'm going to place the probe indicator. Again, that's your dot side of your probe is going to be pointed upwards towards the patient's chin. I need to locate the patient's xiphoid process. Now, when you're going to do this, again, it's where the ribs meet. There's a little spot right there in the center. Don't push hard on it. It's uncomfortable. And so, again, you want to know where it is because you don't want to place your probe right on top of the xiphoid and then start mashing down. It's going to hurt your patient. So let's go ahead and place the probe here, all right? And I've taught this scan many, many different ways. We've done it where you visualize the heart, then you find the IVC. Some people do it in cross-section first, all different ways to do it. This, having taught it many different ways over the years, this is the way I prefer to do it now. But again, if you've learned a different way, that's okay, as long as we all get to the same thing, which is a good visualization of the IVC. Now, I've started right in the center. And if you start right in the center, chances are you're going to be right in between the IVC and the aorta, all right? But I still want you to start in the center. So if we look here, what we can see at the top of our screen, we've got a little bit of heart, okay? And we've got a little bit of liver. That's perfect. We're using our liver as our window to look into the abdomen. Liver, again, is really good at transmitting your ultrasound image. Now, in a perfect world, what I usually have my trainees do is first identify the aorta, right? Because the most common mistake that you're going to make when you're doing this scan is you're going to be looking at the aorta and you're going to say, hey, that IVC looks good, but you're not looking at the IVC, all right? So since I know I'm right in the middle, if I look to the patient's left, right, so I'm going to fan the probe this way, I should find the aorta. Now, I happen to know in my patient today, his gastric bubble is not allowing us good visualization of his aorta. It's right here, but we can't see it very well, but that's okay. Now we're going to look over to the patient's right, and I can see he's got a beautiful shot of his IVC, okay? Now, some things that are going to help me know that it's the IVC. One, it's touching the liver, right? If I were to, when you get a good view of the aorta, you'll see that the aorta itself doesn't touch the liver. This does, right? That's going to really help me. The more you do this, that's something that jumps right out at you. Oh, it's the vessel that's touching the liver. Additionally, I can see here that I've got the hepatic vein entering into the IVC. You can see it dropping through the liver right into the IVC, okay? So now I'm pretty happy with my picture of the IVC. I can also see, even now with him just spontaneously breathing, I can see change in the diameter of the IVC just with respiration. Now notice, if you look really closely at my hand, I'm at a little bit of an angle, okay? Because remember, we started right in the middle. And that's okay. I can see the IVC all right, but it's a better scan if I can slide over and get perpendicular to the IVC, okay? Now I'm right on top. My probe is going straight up and down. And that's really important because when I have the patient sniff, if the probe were to move up and down, okay, and I'm at an angle, it might look as if it's collapsing when it's not, all right? So now I'm pretty happy with my picture here. I'm going to go ahead and freeze it. Okay, remember we didn't have to time our freeze. We can slide back through time. And I'm going to look, say, where does it look the biggest? That's pretty good right here. And so now I'm going to go ahead and take a measurement. And so to take my measurement, I'm just going to go ahead and, I guess this one can even do it auto. Let's go ahead and slide over here. Now, we can see this is our hepatic vein right here. So I can go right next to the hepatic vein, okay? And now I'm going to slide down. Ooh, got a little bit of a curve there. All right, and I can see my measurement. Well, with my curve, I've got 2.6. Let's go ahead and take another measurement. 2.4 centimeters, okay? Which is about what I would expect, 2.4 centimeters. That falls in the normal range. We'll get to interpretation in a second. Next, we're going to unfreeze. We're going to get our image back again. And now we're going to look at collapsibility. Now, if you have someone who has a really tight window, all right, where you're really worried about getting a really good image, next time don't pick your probe up, right? If it was really hard to get that picture, leave your probe there, all right? But with our patient today, he's real easy. So now we're going to have him go ahead and take a sniff. We're going to look and see how much does the IVC collapse. All right, so we can see with just a gentle sniff, he completely collapses his IVC. So we can feel pretty good that his CVP is normal. Let's go over how to interpret that, though. So the first thing I always do when I'm trying to figure out how to interpret the IVC is I'm going to start with diameter. If you have a really small IVC, less than 1.5 centimeters, you know that their CVP is almost certainly low, right? And you'll definitely see this. You're looking at patients with sepsis, right? Where sometimes you actually have trouble finding the IVC because it's completely collapsed. I've seen this over and over again. We're searching and searching for the IVC, and it's completely collapsed. You can actually have the patient just do a little Valsalva. Sometimes it pops open, and you can identify it, all right? You know that that patient's CVP is low, all right? Similarly, if they've got a diameter that's greater than 2.5 centimeters, you're going to feel pretty good. Their CVP is high. With a slight caveat, in young, healthy people who are trained athletes, occasionally they can have a slightly large IVC that can be normal. So again, we make sure you're putting that into clinical context. Now, if your IVC is between 1.5 and 2.5 centimeters, right, that's normal. You can't interpret that more, right? If it's 2.4 centimeters, that doesn't make it more likely that your patient has an elevated CVP, okay? So you know the diameter is normal. You can have a normal diameter, though, and still have an elevated central venous pressure. That's where the collapsibility comes in, right? That's why we did that. So we said, okay, his is 2.4 centimeters. That's normal. Now we need to take a look and see how much it collapses. He went ahead and sniffed. We saw he completely collapsed his IVC. Anything greater than 50%, we're going to go ahead and call that normal. Their CVP is almost certainly normal, and you're done, okay? Now, if it doesn't collapse 50%, if you see it kind of barely moving, you need to take that into account. And now you should be worried that their central venous pressure is elevated. Now, the difficulty of this scan is, again, as with everything we do in POCUS, you need to bring in some clinical context, right? So not all sniffs are created equal. So our patient today was very good at generating a nice, clean sniff and collapsing his IVC. But that's not going to be every patient. Now let's imagine that our patient is an elderly person who's confused and quite ill. And I say, hey, sniff for me. And they're having trouble understanding. That's going to be a much more difficult IVC to interpret, right? Their slight inhale isn't really going to collapse their IVC much because they're not generating a lot of negative interthoracic pressure. Similarly, now let's imagine you've got a patient with pulmonary fibrosis or an asthma attack, where every time they need to take a deep breath, they need to generate a lot of negative interthoracic pressure. That person is going to be much more likely to start collapsing their IVC when they take a deep breath, because every time they take a deep breath, they generate all that negative interthoracic pressure. So this is where you, as a POCUS practitioner, someone who does point-of-care ultrasound, you need to take the whole patient into consideration, okay? What was that sniff like? What is their underlying lung pathology like? You need to bring that into your interpretation as you're trying to understand what their central venous pressure is. So finding the IVC is easy when it's easy, but there's going to be many times where you go to look for the IVC and you just can't find it, the way we just went through it. Sometimes it's because the patient has a large stomach bubble, there's gas in the stomach and it's getting in the way. Sometimes their liver's a little bit high up under their diaphragm, or they've got a lot of gas in their transverse colon. Sometimes you honestly just don't know why you can't get the pictures you want to get, and it can be very frustrating. So let's start where we were before. So remember, we were down here below the xiphoid. Now, one thing occasionally what I'll see is the reason we're not getting a pretty picture is because you're kind of straight up and down like this, right? And again, you really need to rock that probe up into the chest, right? So notice we're straight up and down, I didn't see much. But look, I rocked the probe up into the chest, and look, now we're exactly where we need to be, and I can find his IVC, okay? So make sure, again, you get that rock aiming the beam into the chest. Another thing you can try is you can have your patient take a deep breath and hold it. So I'm going to go ahead and take a deep breath. Perfect. And now look at that. Our picture just got a lot better. Look at that beautiful picture of the IVC, right? So that works really well. Again, not all of your patients are going to be able to take a deep breath and hold it. We all know that, okay? So where else could we go? If this area is not working, you can try to go up onto the ribs themselves. Now, you need to look around to see, can I get a good spot here? all right, where the picture's nice and clear, all right? And that can take a little bit of movement. Sometimes you just land it right on it, perfect, okay? But what I'm going to do is I'm just going to slide around here and then say, oh, look, now I've got a good picture of the IVC. Now, if you look at this picture, the problem is I don't know where in the IVC that I am. I have a general idea. But again, when we're trying to take good measurements, we need to measure the IVC, that diameter, either 2 to 3 centimeters from the right atrium or right where the hepatic vein enters the IVC. That tends to be right in the same spot, okay? So if I just have any random spot on the IVC, I don't know where I am, so I don't know what diameter it should be. So I need to look around. Can I see farther up into the chest? And notice to do this, I'm rocking that probe again, okay? I'm rocking the probe to send the beam up into the chest. And there's our IVC, and I'm rocking it in, and now I can just see the hepatic vein entering right there at the edge of my screen. I've got a little bit of lung that keeps trying to get in my way, but I can see the hepatic vein entering there. I should be able to take a good measurement. Now notice this angle that I'm at. This makes me a little bit nervous, okay? Again, if you imagine the IVC as a circle, and I want to look at collapsibility, well, when my patient does their sniff, if the IVC were to move anterior or posterior, okay, it'll look as if it's collapsing when it's not. So you do want to be a little bit careful when you do a sniff test and you're at an extreme angle like this. You may interpret that incorrectly. So you really want to take that into account when you're trying to interpret your images. Now let's say this isn't working either. You've got one more shot. And to do this, I'm actually going to switch us over to abdominal mode, okay? And the reason for that is, you could do it in cardiac, but I'm so used to being over here on the mid-axillary line. I'm always looking for pleural effusions there. My brain is just set to always be in abdominal mode when I'm in the mid-axillary line. It just helps me out a lot. So I'm going to have my patient just go ahead and place their arm behind their head, all right? And now I'm going to be looking right along the mid-axillary line. Again, I'm going to look for a really pretty picture through the liver, and look at that. You put the probe on there, and the IVC just jumps into place. Okay, it's right at the bottom of the screen. I could give us a little bit more depth if we wanted to, maybe center it just a little bit better. We can see the hepatic vein entering. That's a gorgeous picture. Now, just as we did before, we can take our measurement, or we could have our patient sniff for us, right? And we can see really nice collapsing of the IVC. Okay, we can feel pretty good that his CVP is normal at this point. Now that's a really pretty picture. Not every one of your patients is going to give you that pretty a picture. Remember, we have a much greater distance between where we're scanning from and where the IVC is. And so if you've got a patient who's obese or just has a very large chest, sometimes their liver might be fatty or fibrotic. It doesn't transmit the ultrasound beam as well. So you could have some problems getting it from this image, from this angle, but it does often work, and it's definitely worth a try when you're troubleshooting and you really want to get that clinical information.